Okay, welcome to the British Transplant Society Guideline Development Workshop. And in this first talk, I want to talk a little bit about how we define the scope of guidelines and how we frame the questions that we're going to ask in order to try and make things as easy as possible as you move forward through the literature searching and the formulation of your recommendations. So I'm going to talk a little bit about defining the overall aims and objectives, defining the scope of the guidelines clearly before you start, thinking about your target audience, who the guidelines are intended for, and then in a bit more detail about how we frame our clinical questions and how we structure those questions in order to define our literature search. So the first thing to think about when you're defining a set of guidelines is what is the overall objective? What are we trying to achieve? Okay, what's the background to the condition? What's the size of the patient population? What's the potential impact of our guidelines? And what's the intent? Is it prevention? Is it screening? Is it diagnosis? Is it treatment? Or is it a combination of more than one of those? And it's really useful to think about what the expected benefits and outcomes might be. Okay, what are we trying to achieve? What do we think we can make better with a set of clinical practice guidelines? So is it to improve outcomes for a particular patient group? Is it to improve safety, reduce the risk of side effects or harm? Is it to reduce variations in care, to improve equality in healthcare? Or is it to make treatment more cost effective, or potentially a combination of more than one of those? Sometimes when you set out to create a set of guidelines, it can actually be quite daunting. You sit there with a topic which is potentially really too big for a single set of guidelines, and you just don't know where to start, and you don't know how to tackle it and to divide it up into meaningful chunks. And the risk if you do that is that you never actually end up developing a set of guidelines because it just seems too daunting that you can never get off the ground and get going. If you think about an example, let's say we wanted to create the UK guidelines for liver transplantation. Now that's a potentially massive topic. You could go all the way from donor management to living donation to recipient workup to the actual transplant procedure, perioperative care, post-transplant management, immunosuppression, infections, retransplantation. All of those things could be within the scope of that sort of big potential set of guidelines. And as a task to try and coordinate that and to try and define that, you're going to find it very daunting, and it's going to be very, very difficult to get up and off the ground and get going. And sometimes when you've got a topic that's that big, it's actually better to split it down and say, okay, we're going to create a series of smaller sets of guidelines that deal with particular aspects of that particular care pathway. So for example, you might have a set of guidelines for workup of the liver transplant recipient. You might have a set of guidelines for post-transplant management of the liver transplant recipient. And it's much easier then to define the scope and to keep it manageable for a single guideline development group to be able to deal with each of those individual aspects. The end result is the same, but you're more likely to get there. When you're defining your scope, you think about things like, well, what age groups are we interested in? Is it adults? Is it peds? Is it both? What is the disease type, subtype? In our case, which organs are we interested in potentially? What's the healthcare setting? Now for transplantation, generally we're talking about tertiary care, but could be inpatient, could be outpatient care. We might be looking at procedures, interventions, diagnostic tests, or a combination of any or all of those. And as I say, think about which aspects of the pathway you're going to include, or should you separate out various aspects of the pathway into separate sets of guidelines? Are you going to exclude any specific areas? And if you do exclude particular subgroups of patients, are you potentially disadvantaging those? Are you resulting in inequalities or discrimination? So if you leave children out of your guidelines on, liver allocation, for example, that might lead to an inequality for that group if they've not been considered fully. So as I say, above all, keep it manageable. Make sure that the scope of your guidelines is something that you are going to be able to achieve as a group within a feasible and reasonable period of time with the resources that you've got available to you. And that scope should be agreed in advance of starting the review or any literature searches by all of the stakeholder groups involved. We'll talk a little bit later about what stakeholder groups you should include, but it's really important that they're all involved in defining the scope to make sure you don't miss out anything that's potentially important or inadvertently resulting in any inequalities in care. Who are your target audience? Who's going to use these guidelines? And it might be primary, secondary, tertiary care, might be a combination of all of those in some sets of guidelines. Which groups of healthcare practitioners, which roles are going to be using these guidelines? You know, it might be allied health professionals, it might be clinicians, it might be a combination of surgeons and non-surgical clinicians. Are patients and carers likely to use these guidelines or have involvement? And if so, think about, well, okay, what provisions do we need to make for plain English summaries and making sure that we've got a nice, clear summary for patients to look at the end of our development process. Once you've defined the scope, you can then start to subdivide your set of guidelines, your overall topic, into a series of subtopics or key clinical issues that you're interested in addressing in your set of guidelines. And usually most of these will be fairly self-evident for a particular set of guidelines. And the key issues are going to be those where there's controversy. So those where there's variation in practice, those where there's a conflicting literature, or those where common practice might not be both best practice. And each section or each chapter of your guidelines will be based around a theme. And then within that theme, you'll have a series of clearly defined questions that you're trying to answer using the evidence and the literature. So if we think of an example here, these are the BTS guidelines for management of CMV in transplant recipients. And when you start thinking about the management of CMV, you can immediately start to split this in and imagine what the sections or the chapters in this guideline might look like. So you're going to have topics like diagnostic testing, like prevention of CMV disease, which might include subdivisions such as prophylaxis, preemptive treatment, vaccination. You might have a section on the treatment of disease, and that might vary depending on the patients you're talking about. And you might think about, well, what are the outcomes from CMV disease and how might we audit those outcomes to see whether our differences in treatment, our guidelines are making any difference. And each of those areas, or each of those key clinical areas, are going to spawn a series of very specific questions that you're going to want to try and answer. So for example, your treatment section might have a section on which drug or dose is the best first-line treatment for CMV, or what is the optimum duration of treatment for CMV in particular groups of recipients. In the prevention section, you might have things like, what does vaccination offer protection against CMV? Should we be vaccinating patients on the waiting list? Is preemptive therapy more effective than prophylaxis, or vice versa? So you can see now we're starting to get down to some very specific questions. And this is really important because these are the very specific questions that it's likely that you're going to find literature to answer. And you're going to find clinical trials potentially that address these individual questions that you can then use those to use as the basis for formulating your recommendations. We can go one step further and split these questions down into a structured format. And this is really helpful. And you'll see this when we come on to talking about searching the literature. When you're defining the search terms, it's really helpful to have your search terms laid out in these separate categories in terms of the population. So who are we interested in, which age groups, which organ types, for example. The intervention or the test we're interested in, and perhaps even further defining that in terms of dose duration and so on. The comparator of interest, and what are we going to compare to? Is it nothing? Is it anything? Is it an alternative treatment? And what outcomes are we interested in? And that might be a combination of efficacy, of safety or harm outcomes, and potentially health economics and costs. If you've got an idea of the underlying literature for a particular question, you may already know what kind of study types you're going to be interested in. Clearly, the gold standard is systematic reviews of randomized controlled trials or randomized controlled trials themselves, but you won't always have that level of evidence available. And sometimes you may have to go back for a particular question and look at, for example, registry data or large cohort studies or case control studies, if that's the only evidence you've got available. But bearing in mind that the further down that evidence pyramid you go, the less sure of your results are going to be, and the less strong the recommendations you're going to be able to make will be. To put that into an example again, if we think about our question for preemptive therapy for CMV, our population might be defined as adult solid organ transplant recipients, or we might define a particular organ subtype if we think there might be a difference in treatment or in the way we prevent CMV between different organ types. The intervention is going to be prophylaxis, but we might think about, well, what duration, what dose, what drug? The comparator is preemptive therapy, but how are we going to monitor, how frequently we're going to monitor, and how long for? What are the outcomes we're interested in? They might be virological outcomes, so viremia or disease, or they might be organ-specific outcomes, so graft survival, graft function, or even patient survival. Or they might be more practical in terms of the implications of our treatment on resource use, so duration of hospital stay, cost of care, for example. And in this case, we know that there's a reasonable literature out there addressing this question, so we might limit ourselves in the first instance to systematic reviews and randomized controlled trials. So to summarize, it's really important to have a clear idea as to what the aim of your guideline is and what the scope of your guideline is before you start the process. And that should be agreed with all the stakeholders, and it should be really clearly laid out what's in, what's out, and why. And then once you've done that, it then becomes a little easier to separate your guidelines up into a set of key clinical issues or clinical areas that you can then subdivide into very clearly defined clinical questions that you can then go away and search the literature and try and formulate recommendations for.